Later, if Max was to lift his arms over his head, that's mainly the upper traps, the lower traps and the serratus, and if he pulls his arms down against a resistance, then the levator would come in to downwardly rotate the scapula. So they'll work synergistically in some ways, but it'll work agonist, antagonist in another. I put some wax on there. I just use a fascial release wax by Songbird and it works very well. So what we can do first of all is going to treat, I've lowered the couch a little bit, and I'm going to use the pads on my fingers and I'm going to curl them slightly and I'm going to reinforce that. So I'm not going to dig in with my nails. So I'm just going to use the pads, the distal phalanx here, and then I'm just going to slowly grip in and then reinforce that. Now, with my body positioning, I have a tendency to place one knee on the couch, so I'm side on. And then, so I'm in this sort of like 45-degree angle. So I come up onto the side here. It's hard to say, let's just focus on one muscle because we can't. Yeah, we're also going to be focusing on other muscles at the same time, like the scalenes are deep to that as well. Yeah, you've got the rectus capitis muscles, you are going to cross the splenius, yeah, and the list just goes on. So apply it just below the occipital. So I'm going to use my 3 or 4 fingers, slowly curl in. My patient is going to flex and then rotate and do that motion. Okay, so they are going to flex and rotate and do that. If it is uncomfortable, we can look at an alternative motion shortly. So that's what my patient is going to do. Now, when he does the movement, I will probably get my fingers to about halfway, but he's gone all the way. So then he would come back and we'd start again. I suggest we take a breath in. Take a breath in, please. And as he breathes out, slowly do that motion, slowly. And I'm going to glide through those tissues. Hard to say exactly how much pressure. We don't want to use too much where we restrict the motion. So we have to allow the tissues to glide under our fingers. Take a breath. And again, so I'm going to come around. If I just change my hand, my fingers are going to come over towards the insertion on the clavicle here. Okay, so let's start that one again. Take a breath in. From there, slowly come round. So I'm reinforcing my fingers and I'm gliding down through that. Come back up, take a breath. And as he breathes out, I glide back through towards the clavicle, the distal end here. Again, coming across towards the scapula. You will get a little bit of a supraspinatus within that supraspine fossa as well. Come down. And again, off you go. Okay, coming down to the lateral border onto the spine of the scapula. So that's working mainly the trapezius and the levator. Now what we can do, you can place one hand over if you feel you are stable enough and strong enough, and I can control the movement of the head, and that would be known as passive, okay, like a passive release technique. You can call it PRT. Come down. So I'm gliding down through that. Okay, so I can control all of it. We can also, if we want to, ask a patient, take a breath in please. Slowly push your head back. So he is activating the muscles for 10 seconds. So it's like a PIR of MET, which means post-isometric relaxation of a muscle energy. After 10 seconds, breathe in. And now he can then glide forward as I repeat the same process. So I can glide through the tissues, knowing we've got a relaxed state. If I asked him to push his head forward, watch your oil on your hands and on the face. Maybe just use a finger just lightly on the forehead. So he's just resisting against you there. Now the tissues relax now, okay? So you could glide through with him pushing forward. So that would be known as a reciprocal inhibition technique. So there's many things we can do here. Even underneath the occipital area, we've got these rectus capitis muscles, the major and the minor along here. Okay, so we can almost he can literally just extend his head a little. Okay, good. And then you can almost glide as he just flexes it. Yeah, you're just doing that. So almost like just a little nod. So you're just nodding. So start there. And then you can just glide through there and come back up. So pretty good for headaches around this suboccipital region. Okay, no doubt you're still going to get part traps, part levator, depending where we are anatomically. Okay. From there. So a few little triggers in there you might find. You might want to release them at some point. Relax. Once I've done one side, I naturally will go over and treat the other side. So we've done some soft tissue technique, mainly for the trapezius and the levator scapulae. Prominent vertebrae, you can see we've got 3 vertebrae here, okay? So C7, if we believe it's going to be C6 and he looks up and it disappears, then it would be C6, okay? But because it stays where it is, more likely it's C7, T1, T2. So rhomboids would come from head forward, C7 and T1, and then rhomboids major would come from T2, T3, T4, and T5. And then they will naturally come down to that medial border. If I ask you to interlock your fingers and pull your fingers apart, you'll see the fibers are here, okay? The fibers coming across will be mid fibers of trapezius because the rhomboids will be a lot deeper. Everything speaks of rhomboids, but they're not. This is the lower trapezius coming down to the lower part of the thorax in here. And relax. So rhomboids are deep muscles. So when you are treating anything here superficially, you will get the mid fibers of trapezius and also the erector because the rhomboids are the deeper structure. Now we have a few choices when we can treat this. And one way is to get the patient just to chin to chest and roll as if you're going to slump. Okay, that'll be the first one we will do and come back up. So what we can do is that. So if I bring my arm straight, okay, I can now use one side or the other side from here. So this one, so I'm going to keep my arm straight, my thumb leading, and I'm just going to come onto it here. So take a breath in, please. And when he breathes out, just slowly chin to chest, and I'm going to glide down through that mid-scapular area. Notice the focus on the erector really, but I still will cross the muscles we've already mentioned. There's the, if you just bring your hand onto your lower back, left one, and you can see the medial border of the scapula. Yeah, just let it relax. Okay, along here. So we've got the medial border of the scapula, so the rhomboids are going to naturally fill this sort of space in here from there. Relax your arm again. Take a breath in, please. And breathe out and chin to chest. And I can just bring my arm over. So I'm going to come around that more that towards that medial border and glide in through. It's hard to say how many times we do this and back, but I suggest we don't do it too many because we could easily irritate the tissues. From there, I can drift to the other side. Off you go and just glide down. Nice little technique, these. From there, if you want to and you feel stable enough, then you can lean with both arms and then you can just drift down from there. I'm not saying you get the same pressure, but it's still quite a nice technique you can do for that mid-scapular region. Now, if you don't particularly like using the neck and slump in, then what we can do is just retract the shoulders a little, good, and then I want you just to round your shoulders. So you're just going to protract. So we start in a retracted position, not too much, because you won't be able to get the hand in there, and then slowly protract. So that could be another way of lengthening the mid-scap muscles and come back. Not the easiest for all patients. Max is doing well. Okay, so from there. If you don't like that one, you can have one arm up like this, and then you are just going to reach. Okay, maybe reach with your straight arm. So you're going to do that. Okay, take a breath in and glide in through. So he is slowly reaching from there. And again, that's quite a nice way. Most patients will be okay to do that technique. So you can glide through as he's reaching. What's also quite nice from here is, can you see it's a natural motion? Do the same again. So reach, but I want you just to rotate with the body there, okay? So take a breath in. So he is going to rotate. So this is a good thoracic exercise as well, because he's rotating his spine as we come in through that. Come back. Maybe swap sides if you want to. I can control him from this hand. Off you go. And I can glide down slowly. Slow down. From there. Okay, so I can rotate him if I want to a bit more. Coming down. So there's a few variations we can do. If I ask my patient to push back against me, we activate. You can see the musculature contracting for 10 seconds. So it's like an MET, muscle energy technique. And it's a post-isometric relaxation. 10 seconds, relax, take a breath. And then you can repeat the same process. Off you go. And then you can glide down through that, okay? And you go as far as you want. Come back. If you place your hands on your mid-thigh, from there, chin down. Yes, we're talking about the mid-scapular area, but there's nothing wrong with going slightly lower. Okay, you have your hands like this or like this, off you go. And just slowly chin down to your chest and keep going as far as you can. Keep going. And he's gliding down there. Okay, so that's more for the erector spina, but it's quite nice to add it in one of the movements. The last one, arms across your chest, please. From here, I can sit, I can cradle, I can get my patient to do most of the work, as in you rotating this way. And my fingers are going to find the spinous processes, whichever level you feel is appropriate. And then the fingers in the gully, and the patient is going to go with me and I'm going to glide. So a lovely way of improving thoracic mobility, as well as treating the erector, mid-trap, and if you are potentially deep enough as I come up towards that mid-scap, in the rhomboids as well. From this one is quite nice because what we can do is fingers, take a breath, rotate slightly to the left. So he's rotating, activating for 10 seconds. After 10 seconds, he relaxes, breathe in, and as he breathes out, I repeat the same process. So it's a good mobility exercise for the thoracic spine. So we've done a few little techniques there, working on the muscles that we talked about, the rhomboids, the mid-fibers of the trapezius, and also the erector spinae. Okay, I hope you've enjoyed the video. This is a fascial wax by Songbird, and we hardly use any. So all we're going to do is put 1 or 2 fingers and then apply enough to that lumbar region where we just have a sheen rather than a shine. So we don't really need too much. So this one is more for the lumbar spine erector. We'll do the quadratus in another video. Now what we're going to do first of all, the patient is going to do most of the movements. What I mean by that is there are 3 sort of like cardinal movements with the lumbar. If we tilt anteriorly and then we reverse that and tilt posteriorly, okay, now the erector muscle is lengthening and the muscle is lengthening. The muscle is lengthening and now it is shortening. That's one movement. We'll also relax. We're also going to induce a side bending, which would be where the patient walks up and down on the spot. And if she side bends that way, as in to the right, then the right facets are potentially in a state of closure and the facets on the left are in a state of being opened and relax. And the third one will be a rotation. It's difficult to rotate as she is, so we'll tend to use the knee to bend, and then the patient can rock side to side. The thing is about rotation and side bending, they are coupled. So it means that when you side bend, for instance, to the left, then the vertebra will rotate to the right. It's actually called type 1 mechanics. But there are a type 2 mechanics as well. And type 2 simply states that if you're in non-neutral extension or non-neutral flexion, the mechanics state that side bending and rotation will be to the same side. Whereas if you're in a neutral position, i.e. where she is now, then when she side bends to the left, the vertebra will rotate to the right. Okay, let's move on. Now, 3 or 4 fingers, find the posterior superior iliac spine, go into the sacral sulci, where the multifidus will sit in that space area here. Get the patient to slowly tilt as far as comfortable so the muscle is hard here. 3 or 4 fingers, as I said, reinforce, and then the patient is going to take a breath in and slowly posterior tilt the pelvis, or bring the pelvis in reverse. Okay, good. And I'm going to glide up through the tissues. Be careful on pressure, because if you use too much pressure to start with, you'll resist the motion from the patient. It's like saying that that's the tissue, and then they're gliding, and the fingers are just gliding through as they are rolling under the fingers. So it's like saying that your fingers don't actually move very far. It's the body is coming under as you are gliding through that. Let's show you again. So tilt again. 3 fingers. Apply pressure. And I'm trying, if I can, almost like to lunge through rather than trying to use my shoulders and lean. I want to try to look after my own posture here. So my fingers, and I'm locking down so they are straight. When you're ready, please. And my patient is rotating the pelvis posteriorly as I'm gliding through. I'm only going to go as far as she goes. Can you tilt again, please? Take a small breath in, and off you go again. So I'm going to go as far as she starts to rotate, but I don't want to go all the way up, because typically the lumbar erector needs to be lengthened, but the thoracic erector needs to be shortened. So we don't really want to continue all the way up. We're just focusing on these two. There's nothing wrong with bringing my hands over and doing the same side, the opposite side, rather than walking round to the same side as the treatment. So I can literally apply pressure here when you are ready. And it's nice and slow, nice and controlled as I'm gliding up through those tissues. Once my patient goes as far as she can tilt And again, off you go. Okay, so we can glide through. The second technique, I tend to put my middle finger together on each hand, cross over my index, so now I've got these 4 fingers that are relatively level, rather than putting my fingers like this where there's a gap on the index finger. So I put my fingers like this. Then what I'm going to get my patient to do is, if you just come up like this, okay, so she's going to go like that. I'm just going to walk around just to show you the demo from the opposite side. So my patient is going to come up like this. Middle finger, start low lumbar, and then as my patient lowers her leg, I'm going to glide through those tissues. Just the erector, not all the way across to the quadratus. Come back up, please. Breathe in. Breathe in, that's it, and breathe out. So I'm going to go across the tissues as my patient is lengthening. Good. And same again, breathe in. So I'll go start low lumbar, and then I can just slowly work up to the upper lumbar spine. So I can glide through. Some therapists struggle with the fingers here because it feels like there's a lot of pressure. Off you go as you're breathing out. So if you find it's uncomfortable, use the heel of the hand, come back up, take a breath in, and I can glide through the tissues nice and slow. Okay, good, come back up. And again, I can also slacken the tissue in, and off you go, I can glide through that. And it works very well. The third technique is rotation. I have a tendency for them to start away from me, like this. Okay, and then either the middle finger, take a breath in, slowly bring the legs towards me. So I'm gliding through nice and slow, nice and controlled. When she goes as far as she can, I will ease off, she will ease off. Breathe in, on the out breath, glide through. If your patient has very tight quadricep, i.e. rectus femoris, because when they bend the knees, the pelvic tilts even more, and she has an increased lordosis when relaxed, then you will struggle to place the legs in this position. You might start with the legs lower, or maybe just stick to the side bending. But in this case, this is also pretty good, because as we are drifting legs this way, this leg is internally rotated, and this leg is externally rotated. So it actually looks at mobility of the hips as well. From here, I would like to go into passive. So I'm using one hand, my heel, and I'm gliding through. And I can ease off this, and I can glide through, and I can control how much or less my patient requires as I'm gliding through. But it means I control all the speed. One MET from here, if you slowly push your legs into my hand, so she is pushing this way. This one is actively contracting internally, this is external. After 10 seconds, relax, breathe in. On the out breath, from here, I'm going to bring her legs towards me, and I'm just going to glide through those tissues. Okay, so we did a variation of techniques through here. And it's a nice way of treating the lumbar spine. Just think every movement they have done, or I've done, we are moving. Okay, so it's not static, it's not isometric, it's all with motion. So where we've got a few variations of techniques and treatment of the lumbar spine erector muscle.